historically we've done over 2,600 lung transplants. So that would include all lung-onlys, includes multi-organ lung transplants. That can be heart lung, lung liver, lung kidney, all done at the same time. It's over 2,600 transplants. Lung transplant, I think, is the quintessential multidisciplinary program with surgery, medicine, nursing, pharmacy, physical therapy, respiratory therapy, speech therapy, and all the other specialties, infectious disease, cardiology, surgical subspecialties, pulmonary rehab, psychology, social work, finance, you need it all. We depend on, for our surgeons to be leading the new ventures there. So there's lobar transplant, there's robotic transplant, there can be living donor transplant. So there's cutting edge things like that patients might be eligible for that could impact their outcomes.
The key message is we're not afraid to tackle any challenging problem or patient. Sometimes that means patients that are older, outside of a traditional age range. It may be patients that have multiple other concurrent medical conditions that might complicate the surgery or the outcomes. The lung transplants are probably the most challenging organ of all the commonly transplanted organs to make work successfully. So a lot of what I do is try and understand that interplay between the exposures, the innate lung host defenses, and then how that unfortunately can contribute to rejection after transplant, and trying to solve how do we improve on that.
A lot of the things that our program focuses on for patients to be able to improve before transplant are things like their physical strength and pulmonary rehab. We emphasize the importance of nutrition going into transplant and through the transplant process. And then also making sure that everyone has adequate support and a team to help them through what can be a big and challenging operation at times.
So the focus of my research is something we call CLAD, or chronic lung allograft dysfunction, an irreversible decline in lung function, probably as a result of chronic rejection over time. The focus of our research and our clinical trials is to reduce or prevent the development of CLAD. If we can do that, patients are going to live longer and they're going to enjoy a more sustained, better quality of life after lung transplant.
The Duke Lung Transplant Program is the only lung transplant program in the United States with an active living lung donation program. We recently hired Hiroshi Date, who is an exceptionally experienced and technically gifted surgeon from Kyoto, Japan, who is the world's leading expert in living lung donation.
In Japan, because of the scarcity of a conventional donor, we sometimes utilize a relative's lung. That is called living-related lung transplantation. That is because of the scarcity of the donor, the part of the lung, not whole lung, from the relatives are implanted to the recipient. So with this technique, that can be utilized for a conventional lung transplantation as well, to match the size of the chest cavity. I sometimes use a bronchial anastomosis, which is closer to the graft, which usually end up with a better bronchial healing.
My work's been centered around providing anesthesia for heart and lung surgery patients. We do a lot in the OR. We care for patients preoperatively to assess their risk and discuss the plans with them and really give them a good idea of what they're walking into. We follow that with taking care of them in the operating room, which can be pretty intense. It's a very dynamic surgery, so a lot of changes that we deal with during the surgery. And then we treat whatever problems might occur, and then once they get to the ICU, we care for patients postoperatively as well. So we have a really large group of cardiac thoracic anesthesiologists that care for these folks. For an anesthesiologist to have a leadership role in the transplant center, that's very unique.
With telehealth, we have the ability to see patients in referral as well as follow-up. So new referrals, we're able to have their records sent to us, have chest imaging where we can review and assess patients, and that element to get them familiar with us, allow our program to get familiar with them, and then proceed with next steps after that if transplant makes sense for them. It's not only something for longitudinal monitoring of patients and patient management, but it can be the initial referral and intake and allow patients to get familiar with us and us with the patient and begin their transplant journey there.
There have been a lot of exciting innovations in immune modulation. There are drugs that now are out for the treatment of autoimmune conditions, even psoriasis, that probably would be really valuable to study in lung transplant. And so I hope we get to the point in 5 or 10 years where we're not just taking the same drugs that were used 20 years ago in kidney transplant, but we're using drugs that are really targeted to some of the biology and problems that happen in lung transplant and the immune responses in lung transplant, and then individualizing them.
So I think some of the things that we're examining now are, number one, how more therapies, medical therapies for things like low blood counts or anemia before surgery might be helpful in reducing the amount of transfusions that patients use and therefore the amount of injury that they see postoperatively.
What we hope to have soon in clinical trials is the ability to actually modify organs. So taking a lung and genetically modifying it outside of the donor before we use it for transplant can then allow us to personalize that organ for each individual. It could make a lung that's more resistant to infection or a lung that's less likely to suffer from rejection, and then provide us longer and better outcomes for our recipients.
We've been able to do research and then integrate that research into our clinical practice. We really set the standard for how lung transplants should be done. What are best practices around not only the country but the world?